Welcome to Grand Rounds. My name is Rebecca Muley, and I'm one of the Grand Rounds co-directors, along with Drs. Adi Talati and Alex Harris. Next week's Grand Rounds will be presented by Dr. Paul Harrison, Professor of Psychiatry and the Associate Head of Department at University of Oxford. The title of his talk is Neuropsychiatric Sequelae of COVID-19 Infection, Incidence, Risks, and Mechanisms. This talk will be virtual, but as with our prior lecture by Dr. Kathy Shear, we will be live streaming here in the auditorium. So please do come down and join us. It is much better to be in community and to watch the session together. And we will do the Q&A live here as well with questions fed in by Zoom. As a reminder, if you are joining us by Zoom, please do use the Q&A feature, not the chat feature. And Dr. Talati, who is our remote moderator today, will feed the questions to me and I will read them out loud here in the audience. We'll also, of course, have our live Q&A here in the auditorium as well. And now to introduce today's speaker and the Rod D. Brickell Memorial Award Grand Round Series, I'd like to invite Dr. Madeline Gould, the Irving Phillips Professor of Epidemiology and Psychiatry, up to the podium. Thank you.
Oh, good. I'm glad to see as many people in person. So thank you for those who I individually grabbed earlier today. So I want to welcome everyone who's here in person, and of course those who, many more probably, joining remotely to the Rod D. Brickell Memorial Award Grand Rounds. This is the 30th Grand Round sponsored by the generosity of Richard Brickell and his family since 1992. I just want to have a call out to say that we're particularly grateful to Ellie, Rick's mom, who died several years ago, and to Norman, his dad, who died a few months ago. And I'm so grateful to have known them for decades, actually. They're just two wonderful, wonderful people, as Richard is as well. And it's now my greatest honor to introduce this year's awardee, Dr. Jeff Bridge. Dr. Bridge is an epidemiologist, and I'm sure he's saying, why am I not just saying Jeff? So maybe I will say Jeff. Jeff is an epidemiologist and director of the Center for Suicide Prevention and Research at the Abigail Wexner Research Institute. It says at Nationwide Children's Hospital. Don't think it says, right, because he's so modest. He's also the Nationwide Foundation Endowed Chair of Innovation in Behavioral Health Research and a professor in the departments of pediatrics, psychiatry, and behavioral health at the Ohio State University College of Medicine. Jeff's research focuses primarily on the epidemiology of suicide and suicidal behavior in young people and improving the quality of care and outcomes for youth at risk for suicide and suicide attempts. He was recently awarded the 2024 Research Award from the American Foundation for Suicide Prevention. And this award reflects the myriad contributions that he's made to prevent suicide. He's authored over 200 publications and has too many federally funded grants for me to mention. But I do want to mention his most recent grant, which is a very competitive grant to get. It's a large P50 from NIMH. It's the Center for Accelerating Suicide Prevention in Real World Settings, ASPIRES. And the goal of ASPIRES is to facilitate integrated research studies of high impact, which all his work is of very high impact, applying innovative, sustainable, practice-based research methods with strong potential to address national suicide prevention priorities and help to achieve the aspirational goal of rapidly reducing youth suicide in the US. Now that's quite a mouthful, but very much a mouthful. And if anybody is capable of achieving these goals, it is Jeff. All his research has greatly increased our understanding of the risk for suicidal behavior and has had a great clinical impact, public health, but also clinical impact. And what is especially remarkable that colleagues unanimously, as I was saying that Jeff would be presenting today, will describe Jeff as a scholar, but, quote, one of the nicest guys I know. And everyone has said that. And so it's my greatest honor to have Dr. Bridge speak with us today. We're going to be presenting the award, a gift to Dr. Bridge. And so if, Richard Brickell and Randy Auerbach, who I have the honor of co-chairing this year's award grand rounds, and going forward, he'll be chairing it. I thought 30 years was sufficient time. So I have the award. Oh, and you know what, Jeremy, I think I saw Jeremy. Jeremy, come up as well. And, so that's good. We already took pictures, so you're saved from that. And then, even though I just took it from Richard, I'll give it back to Richard, who can give it to Jeff, because it's with his generosity that this is possible.
So we're thrilled and excited to have Dr. Jeff Bridges here as our 30th honoree. I always say that, my family suffered and we turned a negative into a positive by forming the Ronald D. Brickell Foundation, and our over 30-year relationship with Columbia has been terrific to have the most fantastic honorees come and give these fantastic talks. So please enjoy. Thank you very much for coming.
Well, I am so honored to be here and to receive the Rod D. Brickell Memorial Award and lecture. I had an opportunity yesterday to see the plaque that has acknowledged the previous recipients, and I am just very humbled to be here presenting. And I want to thank Richard and his family for making this possible out of tragedy, something that potentially can help the field and prevent suicide across. Thank you. Oh, sorry. So I just want to thank you. Today. Don't go anywhere, Simon. Okay. So before I begin, I just want to take a moment because when we're talking about suicide, sometimes this can be, as we know, a very difficult topic. And so self-care is very important, and just know that there is help available. The last time I was here, I think was in 2007 or 2008 for the antidepressants and suicide risk in children conference that Columbia sponsored. And I remember sitting in the audience and just being so nervous to stand up here. I looked around and I know the history of this institution. And I thought that might dissipate over 17 years. But it hasn't. So I'm very much honored to be here today. So my talk is going to be, I'm going to talk about the epidemiology of suicide in young people, just a very brief overview, discuss the importance of pediatric primary care as a site for suicide prevention, and then describe, Dr. Gould mentioned the P50 Center that we have, the signature project of that's actually implementing suicide prevention work in pediatric primary care practices. So to begin, just to orient you to this slide, represents the 10 leading causes of death in the United States. The numbers are for 12 to 17-year-olds from 2020. Suicide is the second leading cause of death. If we looked at more recent data, the rankings of the top 3 causes of death have remained the same. Suicide claims more lives among young people in the US than 7 leading medical causes of death combined. What I wanted to do here was to just show suicide rates in 12 to 17-year-olds in the United States and in New York. I have a whole slide deck where I talk about statewide suicide prevention, and I usually refer to New York and New Jersey as 2 model states for having some of the lowest suicide rates in the country, but also for having some of the most innovative suicide prevention programs in the country. And just to show, in both the US and in New York State, suicide rates had decreased. And in 2007, that was the lowest, that was the year of the lowest suicide rates over the last 22 years. But there's been a slight divergence in patterns. So in the US, the highest suicide rate was in 2018. It dipped a little bit and went back up in the most recent, or in the second most recent year of COVID. Different pattern in New York. New York's highest, the year of the highest rate was in 2016. And you can see a slightly different pattern, more of a dip in the first year of COVID and a subsequent increase. So many factors could be related to why New York State has a lower suicide rate. One of them, I think that's important to recognize is method. So in the US, about 44%, 43% of youth die by either hanging suffocation or by firearm. When we look at the data for New York State, it's 21% by firearm. New York State has some of the strictest firearm laws in the country, and some related the child access prevention laws for youth. I'm not going to go into more about underlying reasons for the differences in the suicide rates, but I did want to just mention that while New York State is in my mind, is a model state for its innovative approaches to suicide prevention. Among adults, suicide is the 15th leading cause of death, but among young people, it's still the 3rd leading cause of death in the most recent data available. Over 4 times as many people will die by suicide in New York State as will die by alcohol-related motor vehicle crashes. And important from where I'm kind of going with my talk today is that almost half of communities did not have enough mental health providers to serve its residents, according to federal guidelines. So now I'm just shifting, this is US data now, so not US New York. And just to show a pattern, these are suicide rates by males and females over the same time period. And what you can see here is males have about a 3 to 4 times higher rate of suicide, and that's remained relatively stable over time. This is for 12 to 17-year-olds. If I had a slide up here that showed a younger age group, you would see a narrowing in the gap between males and females. Suicide rates among females, especially over the last decade, has increased at a much higher rate than among males. When we look at self-harm rates, so there's a sex gap in terms of attempt rates and suicide rates. So we see a reverse of this pattern. And actually, we see a much higher rate over time of, these are self-harm presentations to emergency departments in the US. And we see that females have a much higher rate and actually an accelerating difference in terms of presentations to EDs over time. One thing in our field that we're trying to be better with is to look at intersections. And so the next couple slides are going to be just intersections of ethnicity and sex and race and sex, just to show some comparisons. These data are for suicide rates. What we can see here is that non-Hispanic males and females have higher suicide rates than their counterparts in the US. If I were to show suicide attempt data, there would be a reverse pattern here, which I in the interest of time, I wasn't going to show it. This is a little busy slide, but let me walk you through it. So these are rates of suicide among females and males by race. And so the dark blue represents American Indian, Alaska Native youth, red Asian Americans, black is in the green. This is a new category that's been added by the CDC, Hawaiian Native and Pacific Islander. And then white is in the sort of turquoise, pale blue, and then orange is another new category, which is more than one race. I met with some fellows yesterday, some T32 fellows and others, and we were talking about ideas. There's given the pause that's happened at here on some research, opportunities to use other data sets, other areas. This is an area, I'm looking at a few of the fellows right now. This is an area that is worth exploring because other data sets like ABCD have explored more than one race as a factor, and there appears to be a higher level of risk that we really know little about. So I'm just throwing that out there while I'm looking at the data right now. One thing I want to highlight is that female American Indian Alaska Natives have a higher suicide rate than males across the board. And when we think of the epidemiology of suicide and we talk about males typically having a higher rate, it does not apply to American Indian Alaska Natives. And I also thought the numbers are very small when you look at the underlying numbers, not just the rate. But I was very surprised to see that the rate of suicide in Hawaiian Native Pacific Islanders for females was at least numerically higher than for males. So again, these are patterns that are worth exploring in the future. We also know there are disparities in suicide rates. The congressional report that was released in 2019 highlighted an age-related racial disparity in suicide among Black youth, with Black youth up until the age of 12 having a higher suicide rate than white youth, but that pattern changes from age 13 onward throughout the life course, with higher suicide rates in whites compared to Black individuals. So how does all of this relate to suicide prevention? Well, what I'm going to talk about is if we can do suicide screening and intervention in primary care, we have an opportunity to apply universal ways of identifying youth at risk for suicide. So it kind of cuts away at disparities that we might have. The one factor that has to happen is that children have to access primary care, and I'll talk about that in a minute. But there's a great opportunity here to do some really good work. I was falling asleep last night, and I remembered that I have been giving a version of this talk for almost 15 years. And in the beginning, it was purely aspirational. It was imagine what we might be able to do if we could do some of this work in primary care. And I'm highlighting the National Action Alliance for Suicide Prevention because this is an organization, if you're not familiar with it, it is the public-private partnership basically driving the national strategy for suicide prevention in our country. Their mission is to champion suicide prevention as a national priority and to cultivate the resources needed to sustain progress. Their goal is that if they could build a research agenda that, if implemented fully, it could reduce suicide and suicide attempts by 20% within 5 years. That was their original aspirational goal. That kind of melded over time into a shared goal with the American Foundation for Suicide Prevention, the 20 by 25, which we're closing in on 2025, and we've seen the rates. And so we know we have a lot to do to get to maybe 30 by 2030. So one of the things that the prioritized research agenda for suicide prevention laid out was if we took a public health approach to suicide prevention, one thing that we could do is let's look at the data and identify large subgroups with high risk in concentrated settings. I then identify effective practices and match them to these subgroups, estimate the results, again, if we could implement interventions fully, and assess the timeline for implementation and research. So at the time that this came out, there were 38,000 suicide decedents in the US. And this is borrowed from their report. And one thing I want to highlight is just almost 17,000 individuals had accessed healthcare within a short period before death. Again, an opportunity for prevention. And so I was asked by the National Action Alliance for Suicide Prevention to come up with some models of what if we were to implement these strategies in pediatric primary care, what might the yield be? And so I went to the data. I just looked to see there are roughly 25 million young people in the U.S. We would expect, based on the data, that about 18 million would have an annual primary care visit. If we just implemented screening in 25% of all practices, that would be 4 million youths who would be screened, and maybe 850,000 of those youth would screen positive, and we could intervene with them. So then when we think about identifying effective practices and matching them to subgroups, we know that primary care practices are often the de facto principal mental health care providers for young people in the United States. We know that more than 80% of young people are going to visit their primary care providers each year. And we also know that more than 80% of young people who die by suicide have had a health service contact with an outpatient physician in the year prior to death. We also know that screening for depression alone is probably not enough, as more than half of those who die by suicide were not known to have a mental health condition at the time of death. So there was a study done by Dr. Jonah Sarno and her colleagues, and it was published in 2005 in JAMA. And it was a model that was based on a lot of the work that had been done, collaborative care models for depression screening in adults. So there, in the late 80s, early 90s, there were a number of studies that started to publish these findings, and they were finding very robust effects for the power of screening and intervening. And in Dr. Sarno's study, it was a randomized controlled trial. They implemented a quality improvement intervention that was really just aimed at improving access to evidence-based treatments, psychotherapy, medications, for adolescents in primary care. The intervention involved expert leader teams, care managers who supported primary care clinicians, cognitive behavioral training for care managers, patient and clinician choice of treatment modality. So whether or not their patients were going to receive psychotherapy, medication, combined therapy, etc. What they found, the take-home message here for me, was as it related to suicide attempts, there was a reduction in the likelihood of attempting suicide observed in the patients that received the intervention relative to usual care. However, it was not statistically significant. So beginning in about 2008, I, along with my colleagues at Nationwide Children's, Dr. John Campo and Dr. Kelly Kelleher, we tried to get grants funded to do suicide prevention screening in primary care and do a similar, more suicide-focused intervention. We came close. Close is not good enough. We came close several times. It was never funded. But we held on to the idea that this work was possible. These numbers aren't important. This was part of the modeling that I was asked to do for the National Action Alliance. Basically, through a series of models, we estimated that there could be about an 11 to 19% reduction in suicide deaths if we implemented fully these initiatives in pediatric primary care. So I'm showing a picture of all of these individuals because it's a huge segue to this is the team that developed the Ask Suicide screening questionnaire, which is widely used as a suicide risk screener. The first individual is Dr. Lisa Horowitz. She is the main PI of the project. If you're not familiar with the Ask, it is 4 questions that assess suicide risk, if any of those 4 items is endorsed, there's a 5th item that is an acuity item that asks, are you having thoughts of killing yourself right now? And Dr. Horowitz, about almost 10 years ago now, was giving a presentation and talking about the importance of suicide risk screening in medical settings. And in the audience was a doctor named Dr. Ted Abernathy. And Dr. Abernathy is the man with the dog. And Dr. Abernathy runs a pediatric primary care practice in Richmond, Virginia. And after her presentation, he came up to her and said, we need to do this. How do we do this? You know, we care about our kids, and this has to happen. And so Dr. Horowitz engaged with her colleagues at NIMH, and I was fortunate that she reached out to me, and I got to participate in this project as well. And I'm not going to go into all the details of how complicated it was, but if you think back to what Dr. Asarno's project was, it was a lot of that quality improvement type of work, meeting the practices where they were. So they implemented this, and in the beginning, they did this for all youth age 12 and above for well child visits. And the receptionist handed an information sheet to parents upon sign-in. I'll show that in a second. And then the ASQ screen was administered by nurses during the initial nursing assessment. And I have to say, so at the time, none of this practice was not screening for depression. They were not screening for mental health conditions at all. So this was a completely new initiative within the practice. They worked it out so that the ask could be scored in real time, and then the physician was notified of a positive screen. So it was really important for the practices to alert the parents. This was in the meetings with the staff, with the teams. They really emphasized that they wanted information that could be available to the parents, because the providers were concerned that the parents might be, some might be outraged because their children were being screened. So while Dr. Abernathy was all for this project, there was a lot of variation across his team in terms of their interest and concern about doing this. So this is one that was developed by NIMH, just sort of highlighting what was going to take place, recognizing that suicide is the second leading cause of death. And I just want to highlight Dr. Gould's work, which we have cited about 1,500 times over the many years, that talking about suicide is not going to put the idea in a young person's head. And so from there, the practice adapted that language for their own flyer that was given to each of the families. So what did they find? 231 patients were screened, 29 patients screened positive, which was about 13%. Of that, 16 had a prior history of attempt. One patient actually screened, this was a patient that was well known to the practice. He came in, was screened, and all of the items on the ask, except a history of suicide attempt, were endorsed. And this was a young person who was an athlete. He had been injured. He had a plan, and he had a gun in the home, and he was planning to go home and use that. And they were able to intervene with him. And Dr. Abernathy has stated that to this day, he believes that they saved a life that day. So only about 35% of the youth had indicated they had ever been asked about suicide in the doctor's office. And again, about 55% had indicated that they made a past attempt. So from here, we were able to publish this paper. And one of the things that came out of here that was really influential for the project that I'm about to discuss is that we were able to use all of that rich quality improvement data that we had to come up with a template and develop a youth suicide risk screening pathway for use in primary care. And the idea here, and I'm going to talk more about this, but it really is about having a process in place to screen and then do a brief suicide safety assessment and try to put the patients into different, I'll call it buckets of risk, but we could just categories of risk with different levels of intervention layered on top of that. And one of the things that Dr. Abernathy's practice was able to do after that, what they wanted to do is they wanted to implement depression screening as well. So at the end of the process, they began using the patient health questionnaire, which I'm assuming many folks are familiar with. Here's a version of it. We know that the PHQ-9, item 9, is a good measure of screening for suicide risk. From our perspective, we've done a couple studies now where we've been able to show that if you layer suicide-specific risk screening on top of the use of the PHQ-9, you're able to identify more youth who are at risk for suicide. And I recognize the building I'm in, and I recognize colleagues who've created other screening tools. So this is just two tools that in primary care, the PHQ-9 is used routinely now, and it's part of a lot of the national efforts to implement depression screening in primary care. But there is the Columbia, which in our hospital, we screen with the ask for patients, and then we use the Columbia as our suicide risk assessment tool. So want to recognize that. Good segue for where we're heading with the discussion. So I work out of this building at Nationwide Children's Hospital, and Dr. Gould mentioned about our P50 center, so I won't discuss that again. But the way our center is structured is that our signature project, we really focused on the continuum of care for our center, and our signature project is called the Stepped Approach to Reducing Risk of Suicide in Primary Care, STARS PC. And then we have, I'm not going to talk about the other ones, but projects that take place in specialty care, acute care, and then transitional care back into the community. So that was the approach that we took. The project that I want to discuss, so Dr. Cynthia Fontanella is the co-director of our center as well, and she is the lead PI of this project, along with myself, Dr. Alex Kemper, who is the head of he's the division chief of primary care pediatrics at our hospital. So he oversees about 15 primary care practices that our hospital owns and operates in the region. And then Dr. Jennifer Hughes, who's a clinical psychologist, and she is really an expert on, she's an expert on implementation science, as well as safety planning and a lot of the intervention components that are part of our design. So STARS PC, the goal is to test the effectiveness of a quality improvement intervention that implements a clinical pathway for youth at elevated risk for suicide in pediatric practices across Ohio. When I read this now, it seems so doable. When we wrote the grant in 2018, we would recruit 2,500 young people across the state, aged 12 to 17, and their parents and guardians. And then we would interview up to 100 providers and staff in those clinics. And this would all go very smoothly. Interviewing 100 providers and staff has proved to be the least challenging aspect of this study. I'm not going to go into the challenges of recruitment and some of the additional things, but if anybody has a question during the Q&A part, I'm happy to discuss. Here is a map of Ohio, and here is where our practices are located. So our hospital is the gold star in the middle. We have one practice, and none of these practices, when we started, were affiliated with Nationwide Children's Hospital. These are all outside of our system. The three practices that are up in the Toledo region are hospital acquired during this time, but they're still on their own electronic health record. They're just beginning a transition, so they were allowed to continue to participate. But as you can see, we are in every section of a lot of the sections of the state. So Dayton, Cleveland area, Ashtabula, Akron, and we're even in Appalachia in southeastern Ohio. Which again has presented some challenges for doing research on top of quality improvement. The thing about our study is that all of the practices currently use some version of the PHQ-9, whether it's the one that was originally created for adults or the one that has been modified for adolescents. And then what we're asking the practices to do, and I'm going to describe the study design in a second, is when they start to receive the quality improvement intervention, we're asking them to layer the use of the ASK on top of the PHQ-9 to screen with that as well. So there's a lot going on in this slide. What are we asking of our participants? So from patients and their families, our primary outcome is a suicide attempt over a 1-year period of screening positive for suicide risk, either on the PHQ-9 or the ASK. Secondary outcomes are suicidal ideation, NSSI, and then satisfaction with treatment. From our providers, we're interested in their attitudes, their confidence in screening and treating youth at risk for suicide, knowledge about warning signs and risk factors, and their buy-in related to this effort. And then from an implementation science perspective, we use all of the QI tools that are available. I am not going to show all of them, but the run charts and the quality control processes we are doing. We have a quality improvement expert on our team who is responsible for setting these up individually within each of the practices. Okay, so just some study phases. I'm going to show a visual of this in a second, but our design is a stepped wedge design. So, and the visual will help with this, but in a stepped wedge design, we have a treatment as usual phase, where all of the practices are doing exactly what they're doing right now, and they're doing it for a certain period of time. We have a training phase that's kind of a pre-implementation of the intervention phase. So we can't just flip a switch and go live with the intervention. We have to begin providing webinars and training modules and prepping the sites for what's going to happen in the intervention phase. And I have a visual of that as well, but it's basically we start about 3 to 4 months before a practice goes live with the intervention. We start doing that. Then the practices actually get the pathway, and that's where we implement all of the QI processes. And then there's a sustainability phase, because we want to see what happens when we pull back from the research team. How well are the practices doing this work when they don't have our support? So this is what the design looks like. I'll walk you through each of it. We have, there's a randomized component to this study, and it occurs at the cluster level. So you see the clusters, we have 6 clusters and we have 14 sites. We have sites that are embedded within healthcare systems that we couldn't separate logistically for the purposes of the study. So instead of randomizing by site, we randomized by cluster. The Toledo practices, for example, all of them are part of this same health system, and same with the Holzer system, et cetera. We wanted to make sure that we had good diversity in terms of urban and rural practices, and large and small. So the way to read this is all of the time that is appearing in yellow is treatment as usual. So the practices that got randomized to the intervention first have the shortest window of treatment as usual. They're going to get the intervention. Our first practices, we had a lag because of all of issues. So our first practices were rolled out in September, and we had to bump the timeline out a little bit, which affected our sustainability. We originally wanted a 1-year sustainability phase, but we had to cut that to 6 months because of other issues. The green represents the intervention phase. So you can see the first practices get a lot of intervention, and the practices at the very end get little. The nice thing about this design is that unlike a randomized controlled trial where you might be randomized to intervention or not, here all of the practices are eventually going to get the QI intervention and stand to benefit from it. How am I doing on time? Excellent. Okay, so to talk about the clinical pathway, this is the basically when we would go into the practices, because we had to recruit all of these practices. So we revised our approach for talking to practices. A few times going out in the field and having a presentation that didn't go well forced our team to really think through about our strategy and simplifying what we were going to ask the practices to do. So this is our flow diagram, basically, of what we're doing. We are asking practices to add a brief screen, the ask, on top of what they're already doing. Use a brief suicide safety assessment, which I'll discuss in a minute, which may take up to 10 minutes typically per patient if a child screens positive. And then to use an approach to put patients in stratified by risk level, essentially. And this is what our pathway looks like. We have the screening layered on top of current practice, the brief suicide safety assessment. I have a depiction of that in a minute. We walk through this. This is through several iterations of effort to get to this. Some of the factors that we're considering. One of the things we know about screening for suicide risk is that a large percentage of kids that screen positive for suicide risk, they're screening positive on the ask because they have a lifetime history of suicide attempt. And if that attempt occurred, I mean, it could have occurred any time, but the parents may be aware of it. The child is either in treatment or has been treated and is doing well. And you can streamline a conversation in clinical practice by drilling down a little bit on if that is the only item that is endorsed on the ask. So we've built in some of that into the general template. If patients fall into the low risk category, they may benefit from a non-urgent mental health referral, but that's part of the clinical discussion. If patients endorse that fifth item, the imminent risk item, and in doing this work across a variety of medical settings, I would say it typically occurs less than 1% of the time that a patient is going to screen positive and be at imminent risk. There's a whole protocol in place to initiate safety procedures. And I want to emphasize that we are not just, the safety features are not just to refer patients to the emergency department. So what we're doing is we're working with each of the practices to identify local providers in the community, have discussions with the patients about whether or not they're screening positive, but if they're currently in treatment, what are some of the resources available either through an emergency department referral or by other means, so that we're not overwhelming systems. And one of the concerns of doing this work is that so many of these practices, current practice is to refer patients who screen positive immediately to the emergency department, which you can imagine you're overburdening the system and you're increasing the likelihood of stigmatizing the child and the family when maybe that urgent referral wasn't necessary. Where a lot of the work happens is in the yellow category, where more work is needed. That's where completion of the brief suicide safety assessment really occurs. It helps to identify a disposition level. And then I'm going to talk about some of the extra elements that occur there, like safety planning, caring contact, text messaging, and then care navigation support. Okay, so the BSSA, This is available on the National Institute of Mental Health website. This is the standard template. That there are 2 pages, and every time I put this up here and I call it a brief suicide safety assessment, it doesn't look brief. But the idea of this is to quickly aid the clinician in making a determination. And so if a determination can be made by asking a few of the questions, that's helpful. If a provider wants to ask more of the questions for their own purposes, to have a better understanding so they can communicate with another provider, that's also fine. But the goal here is that it walks the providers through a series of questions to essentially arrive at a disposition decision. I'm not going to talk about safety planning. I have slides that actually go through it, and then remembering the audience. Our work is wholly informed by the work of Dr. Stanley and Brown. We've been collaborators for a long time, and so what we're doing in our study is we were funded through our state that we could call into a crisis line in real time and have our providers in the practices call a crisis counselor who would complete a safety plan over the phone with the family or through telehealth. What we found is that was not working. Our hospital system rolled that out in a variety of other settings and found that it was just not working at all. And so they told us after we got the grant that they were not going to support that effort. And so what we've done with Dr. Hughes's support is we've developed an approach. We've worked with now Dr. Brown and Dr. Kelly Green to just implement a way of training the providers to do safety planning within their practices. And so far, the providers have been on board with this. We'll see how good they are at maintaining fidelity to the model, but that's a change that we had to make in real time. So again, I think I talked through this with the suicide safety assessment. Our caring contacts. So I'm assuming most people are familiar with caring contacts. If you're not familiar with caring contacts, the original caring contacts study was done by Dr. Jerome Motto. I think it probably began in the late 1960s. It went into the 1970s. And Dr. Motto was a psychiatrist who was treating adult patients on inpatient units, and had the idea of maintaining a social contact after patients were discharged. And it was unidirectional. The letters that they sent, it was postcards, and it was to support the patient and just say, hey, we just want to know if you ever need help, we're here for you. Today could be a better day, just supportive messaging. He eventually did a randomized controlled trial. And for the longest time, it was the only study that actually showed a significant difference in decreasing suicide rates in patients that received the postcards compared to the usual control patients. And so what we've done at our hospital system is we worked with young people with lived experience. And this is Dr. John Ackerman in our group and his team. And we developed caring contact text messages with their input. And this is an example of just one. I think we have about 20 so far that have been created. And there's an encouraging quote, like, sometimes just getting up and carrying on is brave and magnificent. It establishes a connection with our treatment team. We remind the patients that we can't respond individually to these messages, although we have gotten some really nice emails or texts back that say, hey, I know you can't talk to me, but I needed this today, so thanks, Autobot. And then we remind the patients of their safety plan, and we make resources available to them. And so the way this is set up, it was originally set up for our our emergency department and our inpatient and youth crisis stabilization unit. But we got a grant through the state to make it available to other practices, so that it had already rolled out to some primary care practices within our network, and we were able to use state funding to make it available in this study as well. And what I'm coming back to is the elements of our design. All the elements are made with sustainability in mind. And so when we pull back the research and the resources, we want to make this available to folks moving forward. So the child gets about, I think it's 19 texts total over a 1-year period. It's a weekly text for 2 months, and then a monthly text for the next 10 months. We also partnered with our hospital system because Nationwide Children's also runs an accountable care organization. And so the hospital is on the hook for about 500,000 covered lives across the state. And as part of that, you can imagine all of the quality improvement efforts that go into running an accountable care organization. And so the system has care navigation built into it. And our patients who fall into that middle category, into the yellow bucket, qualify for care navigation through this system of care. So we link those families with care navigation. And the idea is to make, as we know, a very complicated system less complicated and burdensome. And some of the ways that we do that, we have a team approach. The care navigators can develop a care plan. Again, this is the joint decision making is really key, and so that's an option. There can be face-to-face visits if necessary. The goal is really to get the patient connected with treatment and let the glue stick long enough so that they're engaged with treatment and can benefit from treatment. So our quality improvement process, if you're familiar with the IHI model, we just implement PDSA cycles. Our goal is to not let perfect be the enemy of the good or good enough. What we're trying to do is meet our practices where they are, hear them out. We have, I'm not going to show the slides, but we map all the processes, the current processes that all of our practices are doing. And then we talk to them about how we can implement ways to do this work within their individual system of care. So even if you're within a healthcare system, three practices are just 3 practices. They all do things a little bit differently. We use basically key driver diagrams. And I mentioned earlier that we use a lot of quality control measures. So for example, one of our aims is we want to increase the percentage of screening with the ask. We know it's going to be 0 at the beginning, and we want that to be 85% or greater within 5 to 6 months of starting the effort, and we want to maintain that. So that's a measure that we're following. We also want to make sure that patients who screen positive are getting need a brief suicide safety assessment are getting that. So we're following that as well. And then our key drivers here are really just working within their particular systems to make this work. So some of it is getting into their electronic health records. Again, I'm happy to talk about challenges, but with each of these things, it's getting data use agreements and working with their IT teams to make this happen, which it can delay things, but when you can navigate all of this and see that it works, it's also really powerful. So these are just some of the ways that we're working with the individual practices. All of the practices have a quality champion on site. These are really the individuals who are responsible for moving the initiative forward, getting other team members, reminding them of what they're supposed to do, and being our individual contacts. We also use simulation training. So our hospital has a simulation lab, and simulation, at first I thought, wow, it's remarkable. And then when I learned it's a lot of role playing, I'm still impressed. I think it's remarkable that we can go out and do this, but We hire actors, young actors from the Ohio State University, and they play patients who are screening positive for risk. And we walk through all kinds of different scenarios with our provider teams to build that comfort level, that confidence in handling a patient who's at risk for suicide. So we have a couple trainings focused on the clinical pathway and safety planning. And then we do like a thorough environmental scan. So this is kind of in its time, which is perfect because I don't need to go there, and thank you very much. Oh, and while we're doing that, so I want to thank my team. So I work with a wonderful group of folks, and I just want to recognize them.